Welcome everyone to the webinar on challenges in pediatric TB diagnosis, where we are exploring the theme of potential of AI in pediatric TB screening. The moderator for this session is Dr. Shibu Vijayan, the Chief Medical Officer at Cure.ai. He has over 24 years of experience working across complete spectrum of public health services and health system strengthening, and he has himself been a pediatric TB survivor. So, welcome all. I will let this session over to Dr. Shibu now. And Dr. Shibu, if you can take it from here, introduce our extremely great panel over here. So, yeah, over to you.
Thank you, Sruti, for that nice introduction. When it comes to pediatric TB, it is almost always actually close to my heart because of my personal experience. Uh, as we know that we have almost like a million cases, incident cases happening every year, and only half of it is being diagnosed. And we know that over the last few years, there has been massive expansion of guidelines as tools came into play, but still, I think when it comes to pediatric TB, it has been falling behind. And among the major chunk of the 50% only being diagnosed, major chunk of it is being undiagnosed in the smaller age group, especially 0 to 4 years. The challenges become which more evident. So we have today
What is
lined
the
up.
requirement? I'll just.
Please turn off your cameras if you're not on the panel or the moderating session.
Sorry for that. So we have lined up today an extremely enriched panel with a wide variety of experience from both from the clinical academic setup, research setup, and also implementation experience. I'm proud to introduce you to Dr. Steve Graham, Professor of International Child Health at the University of Melbourne. Dr. Graham is a pediatrician and professor of international child health, and at the University of Melbourne with over 20 years of clinical and research experience. He specializes in improving childhood health outcomes, particularly in resource-limited settings and the Asia-Pacific region. His research focuses on child and adolescent TB, pneumonia, and invasive bacterial diseases. Currently co-leading a comprehensive community-based screening for disease and infection in a very high TB and MDR TB prevalence setting in Papua New Guinea. He also played a pivotal role in shaping guidelines for pediatric TB management in collaboration with the World Health Organization and national TB programs, as well as in deployment of tools for training and implementation as a senior technical advisor on child TB and lung health with the Union. Welcome, Professor Graham, to this panel. I know that there is an opening presentation from your side, but let me just finish introduction of all the speakers, and then I'll ask you to actually deliver the presentation. So we have the second panelist, Dr. Devan Jagannath, who's an assistant professor of pediatric infectious disease at UCSF. Devan specializes in improving care for children and with tuberculosis in resource-limited settings. Dr. Jagannath completed his pediatric residency at Johns Hopkins Hospital and his fellowship at UCSF. Is actively engaged in clinical care at UCSF Children's Hospital, where he treats a variety of infectious diseases in children. His research focuses on advancing the diagnosis and treatment of childhood TB, published studies with TB co-infections and innovative diagnosis. Dr. Devan is an investigator in multi-country projects, including USAID-supported ADAPT TB, Capture Consortium, and NIH-funded R2D2. We do have Dr. Martina Kesenki, who's the director of a TB program at Elizabeth Glaser Pediatric AIDS Foundation. Dr. Kesenki is the director of tuberculosis program at ECPAF and has been an advisor to MSF. With a strong background in pediatric infectious diseases, she leads efforts to enhance TB detection and treatment for children in high-burden countries, with a focus on sub-Saharan Africa and countries. Dr. Kesenki also played a pivotal role in implementation of UNITAID-funded catalyzing pediatric TB innovation CAP TB project, which aimed in improving TB case finding. She was actively collaborated with the global organization, including WHO, to advance pediatric TB care lines, and has made significant contribution to global discussions on child health. Welcome all to the panel. So we are going to hear a lot of advances happening in the TB diagnosis, in pediatric TB diagnosis, as well as a lot of AI in revolutionizing the TB screening among the pediatric age group. Over to Dr. Steve for his presentation, opening presentation, and then we will actually invite other panelists to comment on and reflect on their experiences. Thank you. Over to you.
Yeah, thanks very much for the kind introduction, and it's good to be here. Can you hear me okay?
Yes.
Yeah. Sariti, could you go to the first slide, please? What I'm seeing on the screen is perhaps a later slide. Yeah, thank you. And I'm sitting here with a colleague in Yogyakarta, Indonesia, Dr. Rina Triasi, who's head of respiratory pediatrics here at Universitas Gadjah Mada and Dr. Sajito Hospital. Next slide, please. I thought what I'd do is just cover perhaps some of the important points I think that will set us up for the discussion. Many of these issues I think you're probably familiar with, but I think the first important one is clearly the critical need in child TB still is improved diagnostics. We have a large case detection gap in TB, and it's particularly highest in young children under 5 for reasons I think we all understand, with the difficulties in diagnosis and difficulties in confirmed bacteriological confirmation of diagnosis in that age group. And that leads to a treatment gap, because if you're not detected, you're not treated. And we estimate that the majority of children who die of TB globally are actually children who have never been detected or treated. And then, of course, there's a large prevention gap, and we have effective preventive treatment for example, for household contacts, which has been universally recommended for a long time, but not particularly well implemented. And in the context of household contact screening, it's important to remember that it's not just about initiation of TPT for eligible contacts, but it's also an opportunity for active case finding as well in what is a high yield, high risk group. So that's an important area for diagnosis as well. Next slide, thanks. And we talk more and more, as we should, about decentralization and integration. And a major focus of the work that Martine has been leading with TB-CAP is evidence being generated to show the impact of decentralization of services. It's important to remember that most children with TB don't turn up to a tertiary specialist centre, but rather first present to primary and secondary care levels, where healthcare workers may not have always had the confidence or the expertise, perhaps, or the training to comfortably make a diagnosis and start TB treatment. And early detection is critical for reducing morbidity and mortality, for improving access by strengthening all levels of care, also for providing treatment support, reducing unnecessary costs for families, such as through unnecessary referrals, and having a more integrated approach around the households, both adult and child, with TB. And within all of this is the critical need to strengthen capacity of healthcare workers at all levels to make a diagnosis or to exclude a diagnosis and start treatment for prevention. Next slide. So this spectrum, I think James Seddon put together, I find very useful, because what it talks to is the challenge we have in trying to adapt chest X-ray AI, for example, which has been widely used now to detect TB in adults. How might that work or not in children? And it's important to recognise that young children are a high-risk group for disease. We know that. As are adolescents, a lot of TB case notifications start to increase, particularly after 15 years of age in many TB endemic countries. But the pattern of disease, radiological and in terms of bacteriological confirmation, changes. And so that, it may be possible to readily get bacteriological confirmation in adolescents who have more adult-type disease, as do their chest X-rays demonstrate that, and so therefore can be detected using the same tools that you might want to use for diagnosis or screening of adults in the community. But children have a different radiological pattern, which is often around lymphadenopathy or disseminated forms of TB, some of which are specific, some of which are non-specific. And then when you move into that under 5, particularly, they often clinically present in similar ways to other children with disease in that age group, such as pneumonia, malnutrition, etc. So it's a group that commonly requires a clinical diagnosis, and the presentation, both radiologically and clinically, can be very non-specific. Next. And so the union has tried to support improving the use of chest X-ray, which is still a major tool, particularly as bacteriological confirmation is only achieved in the minority of children with TB or pulmonary TB. And the union has definitely been trying to support improving the confidence of healthcare workers to interpret chest X-ray. Next slide, thanks. And there is a need for an algorithmic approach. There's treatment decision algorithms that are now being we're talking more about, but also in the context of chest X-ray reading. First, to decide whether the X-ray is normal, then if it's abnormal, to decide whether it's features specific to TB or perhaps not. And now that we're using treatment regimens, or 2 different treatment regimens, a 4-month regimen or a 6-month regimen, there's also the possibility of using chest X-ray to decide whether or not which are the regimens the child should be treated for. So whether it's the shorter regimen or the standard 6 months. Next slide. And so for some children, of course, I'm sure we could develop pediatric AI, chest X-ray AI, to read abnormalities in children, such as these with very obvious hilar lymphadenopathy. But unfortunately, many children with TB don't present with very obvious specific changes such as these X-rays. Next slide, thanks. And so this child also has TB, and if you look at the AP, you may not be too certain as to what the abnormality might be, and if it's abnormal, whether it's actually TB related. And we often say in pediatrics, for example, our lateral chest X-ray could add that much more, but that's usually not part of your screening. And so I guess we have to consider, at least today, what are we talking about? Are we talking about the use of, if we're talking chest X-ray, is it in the context of AI for screening, or is it in the context of AI for diagnosis? And they're not necessarily 2 of the same things. So I might stop there, I think. There is obviously other discussions we might have around AI for other potential uses in child health in resource-limited settings, but I thought I might just stop there and say thank you.
Thank you so much, Dr. Hamid. This was actually useful, and you set the expectation and also flag the challenges, even if you kind of how are you positioning AI in this diagnostic algorithm, especially when it comes to chest X-ray, whether it is a triaging tool or a clinical decision support tool. So probably, I mean, hopefully, like we'll hear from other experts as well, what are their thoughts on it. I'll just move to Dr. Devan. Devan, you have been actually kind of playing pivotal role in pediatric TB researchers and kind of like have set up systems to capture information and data sets for creating new tools, and also tested and rapid adoption of new tools in the field. So what are your initial reflections on how can AI chest X-ray being deployed, can developed and deployed easily into this pediatric TB detection, given your experience and also like your current work in pivoting some of the researches?
Thanks, Shivu, and thanks for inviting me to join this esteemed panel to talk about kind of the role of AI in general. And so I think Steve outlined well that, part of the challenge is how can we identify really tools that are serving the unique needs for children and for childhood TB specifically. And if we think about gaps today in AI in general and AI for children, we don't necessarily one, have data in the settings that we seek to serve in particular, and second in children that kind of serve, again, their unique needs. And then within TB, as Steve outlined, whether it's looking at hilar lymphadenopathy for a chest x-ray or other phenotypic complications outside of even the lungs, we just don't really traditionally develop tools for these populations, unfortunately. And so how can we build the infrastructure to kind of support and enable developers to envision a way to make these tools for children, and also empower providers, researchers, and importantly, caregivers and their children and adolescents to kind of create a voice to create these tools specifically for them. And so I think through some of the research efforts that I do and others on this panel, it's really how can we create in the CAD space, for example, create a repository of data from well-characterized chest x-rays as one example, in order to support that development. And again, engage directly with developers and with the community to ensure that they actually have access to develop these tools and evaluate it.
Cool. So when I'm deviating to Dr. Martina. So Martina, in your in the current work, and United has done significant work in pediatric tuberculosis, especially, and also under the United project, CAP-TB project. Also actually try to kind of figure out what are the new tools being utilized in the field, how we can actually generate evidence from that, and also did country assessments to look at the preparedness, what is the existing algorithm, how are they adopting, how do they take that to the larger NTB goals with respect to pediatric. Any lessons when it comes to, so given you have seen that, any lessons it comes to the penetration of X-rays? I have read that in one of your framework. It was the X-ray was one of the key things which you also evaluated, whether that presence of X-ray in pediatric algorithm. Having listening to all these things, so X-ray is already there in the pediatric TB diagnosis system. So how AA can, so if you would want to kind of look at when Dr. Graham mentioned about the decentralization part, there has been advances made earlier with empowering health workers with checklists, tools, reading X-rays, and then given your experience in working with 10 countries to kind of increase pediatric TB, what are your lessons to share, and also some of the insights from your side?
Thanks, Shibu, and thanks also for the invitation to contribute to this panel discussion. I must say that during the implementation of CAP-TB, while chest X-ray was there, as you said, the access to it was challenging across all the 10 countries where we implemented. Just to remember, there were 9 African countries and 1 was India. In India, I think it's where access to chest X-ray was less problematic, but across the African country was problematic because of different reasons. The first one was to have functional devices available. The second one was to have trained healthcare workers to able to read and interpret the chest X-ray. The third one, I must say, was also a cost. In several countries, chest X-ray has fees, and most of the families and caregivers could not afford it. So one of the interventions we tried to introduce is also, and with a lot of advocacy with a national program, was to remove those fees, at least for the below 5 years, because this was really problematic in ensuring the access to the chest X-ray services for the children who need it. So it remains a challenge. This is my main message. And when we implemented the project, digital chest X-rays were not there yet in the places where we implemented. So this is changing now slowly. Global Fund is providing a lot of support, but at least from what I'm seeing, the number of digital chest X-ray that are being procured is still limited. So it will take a while before the platform of digital devices is expanded. So I think where the CAD or computer-aided interpretation of chest X-ray can really come in is really to help improving this access, especially when it comes to the capacity to interpret and read and interpret the images, which is certainly still a huge gap. There are other issues that we need to address, is like the availability of the digital chest X-ray and the fees, because if we unless we think about the comprehensive package, there will always be bottlenecks that prevent children to access properly the services.
Thank you for that. I think that's a critical point. So software can only solve some part of it, but there is a lot of infrastructure gap existing. Even if there are X-rays available, you did mention about the digital X-ray availability, which also is a bottleneck when it comes to software. Though there are solutions to overcome it, but again, the accuracy of that also would be, suboptimal. So thank you for bringing that, because access is not only for the hardware, there are economic barriers to get the X-ray done, which is also a critical challenge. And I know I'll come back to you on your call to action, which is also a rich document to kind of listen and understand how countries could overcome these challenges, and which has been again nicely depicted. So coming back to Dr. Graham, so I know that WHO in the current, the last global TB report has kind of mentioned and as an ambitious statement saying CAD for TB, computer-aided diagnosis for adult has been in practice for several years. So now it is time to think about CAD coming into the pediatric age group. So, and you did mention about the bifurcation between how are you positioning, is it a triage, and mostly in adult population it is almost exclusively is the triage tool. Whereas the need, which what I am hearing from the larger group, is that a need here is much more a clinical decision support tool. Like, what are your thoughts on that? How we can actually, as manufacturers, come together to kind of solve that problem?
Yeah, no, it's a great question. It's an important one to consider. I guess I can only give my view. The CAD for TB that's being employed in adults, as you say, Shibu, is largely being used, as I understand it, as a screening tool for active case finding. So symptom screen or chest X-ray screen score by CAD for TB abnormal. You then give sputum, the for expert or whatever it may be. So the actual next step is diagnosis, but the CAD for TB may assist in the diagnosis, but it's not being used as essentially initially as a diagnostic tool, if I can make that point. And so, and it's been validated for adults, and that's where we're using it, for example, in Papua New Guinea. And the only challenge we're really finding is there's so many people in that community who previously had TB that we're finding a lot of abnormal scores amongst people who have been previously treated and different things. But it's not essentially, if an adult's picked up as having an abnormal CAD for TB score, then they need to then take the next step towards getting a diagnosis with hopefully bacteriological confirmation. So this is the difference then with kids. So what do we want to use it for? Why are we doing active case finding studies in adults? We're doing it to detect and treat people in the community with TB, including people with subclinical disease and who are not yet symptomatic. And one of the main drivers is to reduce transmission and bring down prevalence in those communities. So there's a lot of differences there with the kids. The kids, if you did a massive case detection of young kids, you might improve diagnosis, but you're probably not going to make much difference to transmission in the community. So it's not a tool for that purpose as such. What it's about is getting kids with TB onto treatment to reduce morbidity and mortality. So it has a different, equally important, but different public health outcome. So do we actually ever need to employ chest X-ray as a screening tool, or do we only really need to develop it to help us with diagnosis? And I think that's an important question, because one of the things that I think with strong evidence feel quite comfortable about is if I went to a household of somebody with TB and I screened all the children, I'd be happy to know that they're asymptomatic. If they're not symptomatic, then I would put them on TPT. I don't need to do a chest X-ray as well. As we move to the slightly older age groups, particularly older children or young adolescents, 10 to 15, maybe we want to have a negative chest X-ray as well before we put them on TPT. So they're just some of the different issues. I see our need is more in the space of diagnostics than it is for screening and active case detection in the community to bring down transmission. I hope that helps answer.
Yeah, so thank you. That helps, and also that also opened up another thing. I mean, the preventive treatment, qualification of preventive treatment, which I'll come back in the next round of questions. So, Devan, you have been actually again in your research, you're also looking at a lot of other biomarkers along with the radiological markers also. So, is there any encouraging kind of evidence evolving to kind of look at? In conjunctions with X-ray, I'm not talking about AI per se, in conjunction with X-ray, any other biomarker can help to decentralize and health workers to make a decision, which is much more like, okay, this is probability of TB is high in the child. So is there anything like which you can share now?
Yeah, I wish we had a single marker that could solve all our problems. That would make our lives much easier and solve this diagnostic gap. I think one thing that when I think about diagnostics for childhood TB is recognizing the heterogeneity of presentation that children have with TB, and that, I think the reality is how can we combine different clinical data, biomarker data, imaging data to help improve the confidence to make that diagnosis. As a clinician, I try to view it from like what would give me confidence to make that decision point, because I think that's really the bottleneck is, we have a child that's coming in with non-specific symptoms, and there's many things, especially if we think about decentralizing TB care, the reality that we should consider is that the majority of times it's actually not going to be TB, it's going to be other conditions. And so how do you support that provider to at least consider TB, make that decision whether to initiate other diagnostic testing or empirically start treatment? And I think that reality will be a combination of providing clinical decision support through an algorithmic approach that involves, prediction tools through clinical signs and symptoms, AI-based tools such as CAD or COugH or other tools, and then hopefully additionally, host biomarkers or microbiological biomarkers that are non-sputum and point of care that can help kind of, again, raise that confidence for providers to make that treatment decision.
Thank you. I think so. What I'm hearing is that a single standalone X-ray CAD won't probably solve a lot when it comes to pediatric tuberculosis. We need much more composite and complex indicators to talk together to enable the health worker to take a decision. So that's a wonderful thought, and also probably your research in the coming days will throw some light on it. As it reaches the conclusion. So Martina, when you worked with many countries and you have seen that various level of maturity, you did mention about the presence of X-rays and access to X-rays in many countries. Which country have adoption capability of new tools, appetite for adoption capability of new tools, and what as a community, TB community, we all need to collectively do to kind of encourage the faster adoption of tools? So probably, some of the work that collectively researchers and academicians are doing are getting a major bottleneck is to kind of take at scale. We do have patchy successes in small places, but again, at scale, it is a challenge. So, but you have done extensive work with the country program. So can you share some thoughts on it?
Yes, thanks, Shibu. I think what helps is really I may be biased, but I found projects like the one that Unitaid has funded useful for this, in the sense that they support the pilot, if you want, introduction, and they as Unitaid likes to say, they are catalytic in their nature. So it really helps the National TB program to get support in introducing a new technology, getting the evidence on how it works, and then informing the scale up. Now, I must say that it's not obvious to go from this pilot to the scale up. It still requires a lot of work. So this needs to be really, it requires a lot of coordination among different implementing partners, different donors also in country, to really make sure that somehow from the pilot the activities are handed over to larger funding structures like the Global Fund or the USAID that can support the scale up. Really having support in the first phase is important, and giving the support to the national programs to really see how it can be the new diagnostic or new tool should be introduced, what is the relevant preparation, etc. It really helps a lot. I think we still have to work as a community on then how we move from this pilot phase to the larger scale up, because for me, this in my direct experience in the different countries where we worked, there is a lot of difference in how this was taken up. And I think although there is the interest from the national program, unfortunately, the gap is a little bit the funding. Okay, they basically when it comes to the big funding envelope like the Global Fund, it remains always difficult to get pediatric intervention rightly prioritized. So where we kind of hit the wall was the availability of funding to continue the scale up at a good pace.
Yeah, I think funding remains, and also the pediatric TB should figure out some of the country asks also to the Global Fund to get that funded. I think it's a bidirectional issue. The country is not recognizing that as a critical challenge and then preparing that for funding requests as well. So when it comes to the preventive treatment, Dr. Graham, one of the key thing is to actually still remains a challenge to uptake of it. And we know that there are now new regimens being tested and shorter regimens are there. Even 4 hours are being kind of recommended in the recent guidelines. There are evidences evolving with the new regimens from 6 months to further shorten it. And here comes again one of the challenges when we actually interact with the field level doctors or even health workers. One of the key challenges is to again convince the parents to say, okay, there is a clear indication to do it. And do you see the tools like X-ray and CAD play a critical role there? And if not, what are the tools available to kind of convince the parents to initiate kids on treatment, especially in the younger age group?
Yeah. Okay. So it's quite a big topic. I just to touch on a number of things. I mean, again, to recognise that yes, we are getting to shorter TPT regimens, or in fact, this week there's now a WHO recommendation for a TPT regimen for MDR contacts as well that has come through, which is all very positive. And yet, as you say, the coverage is inadequate, and the business of convincing parents who have children that their child needs to be treated with a drug every day for 3 or 6 months is very challenging. We also moving to an era when rifapentine, for example, will be able to be used in all ages with child-friendly preparations. So you'll be able to use a weekly regimen instead of a daily. There are all of these things, but if I can just go to 2 points. One is the value of chest X-ray, as you said. So ideally, as the study, by contact study that Martina was leading, showed that a decentralized or community or household-based approach with community health workers and nurses going to the households, you got better uptake and initiation and completion of TPT. That is not surprising, but it's great to have the data to the evidence in such a quality trial. It's not surprising. From experience in terms of convincing parents, the things that really are required is community engagement, community having confidence in the health workers who come to their homes, community engagement, as we use a lot in Papua New Guinea, and some tools of education around understanding what latent TB is, or latent or sleeping TB, or whatever it might be. That's a really critical thing, because it's quite a challenge sometimes to convince people that these children might benefit from these medicines and not be a great risk. So where does chest X-ray fit in all of this? Well, I think for young children, we're always happy, as I said earlier, just for screening with symptoms. And only those with symptoms did we then want to go and try and make a diagnosis or rule out TB using chest X-ray. So that's a critical role of chest X-ray. But that's only a subset within those households. Usually 20% of kids in a household will be symptomatic of some sort. So it's the minority of kids who need to go somewhere to get a chest X-ray done. Whether you can use a CAT for TB type of chest X-ray or an AI chest X-ray, or whether they need to go to the facility anyway to be weighed and to be clinically assessed and to have a chest X-ray, wherever that might be, I think we could discuss. As we move towards TPT for older age groups, including young adolescents, we don't really know whether they, like older adolescents and adults, really do need a chest X-ray before they start TPT, because they may have subclinical disease that is bacteriological positive, and you don't want to but we don't really know that. So there's some evidence required there. So I guess that's it for me. I mean, I think we're still not really sure how we could optimize. I think we certainly know that to move TPT services as close to possible to home, and we have already some of the tools to support that. But where chest X-ray screening versus chest X-ray diagnosis might best fit in, I think there's still some uncertainty. Thank you. Sorry for the long answer.
Thank you. Yeah, no worries. I think that requires a lot of research. I think probably Devan, you can actually throw some insights on anything on TPT thing. I mean, in the pipeline, specifically to cover this points Dr. Graham mentioned. So, and also one more, adjuvant question, I would say. So we know that now there are clinical criterion being used for treatment duration calibration, right? And radiological finding is one of the key things which again there is an atlas which is Union and WHO been published, wherein helps in kind of segmenting severe and non-severe thing. And Dr. Devan, any research based on that being, now that we have evidence of short regimen uptake, it's also kind of abysmal. Because given the lack of confidence of the clinicians to take it, or health workers to take a decision on it. Anything on that research evidence is evolving on that part, and also on the TPT thing? Thank you. Over to you.
Yeah, thank you. And I think, well, I'll just say that I agree with Steve, which is usually the right answer for many things. But I think at least, in its role to help as part of evaluation of symptomatic children, and then help to stratify, I think, even children that, are eligible for TPT can be valuable. I think sometimes we're just very focused on, okay, they have a normal chest X-ray, they don't have TB or TB disease is the focus, when in reality, making sure that can trigger and be linked to decision support for the provider to say, this is normal, they don't have symptoms, initiate TPT, is an additional tool that, can be linked in with not just the chest X-ray read, but actually some clinical decision making, I think would be important. But for stratification, I think we have to take a step back and appreciate that we're entering a new era in terms of treatment decisions, and a recognition that we often have focused on treatment in order to reduce kind of the relapse and recurrence in the most severe disease. And that's kind of how duration has largely been driven, and it's been kind of a one-size-fits-all. And so as a field, we're kind of shifting to, whether you call it a precision medicine or a stratified medicine, but really it's kind of it's recognizing that individuals that have less severe disease likely could benefit from shorter regimens. And within pediatric TB, that's a huge population of children that are paucivacillary or have non-severe disease, and that whether it's with the SHINE trial, to have that really further define that we can move to shorter treatment regimens has really been revolutionary, really, to think about novel studies to decide that. And then also for the current recommendation for the shorter course, think about how to best implement that, because I think that's been a large challenge, is that in particular, the current criteria to kind of determine severe and non-severe is kind of heavily dependent on feeling confident again in that, in reading the chest X-ray and making the decision that they meet the criteria to make the decision. I think that has been a challenge, and Martina can also probably speak to this, as countries think about how they're going to adapt this to their guidelines, it has not been as straightforward. And so I think ways to improve the reliability and confidence again of providers to make that decision would be valuable, and that's where CAD or other AI tools could be done. And so to that extent, I think, again, with our cohorts and data sets, we are able to then try to link some of our data that does stratify by severity and see if there are correlations with CAD or other tools to try to make easier prediction methods. And for future trials, kind of thinking about how can AI be integrated into the decision to implement a shorter regimen.
Yeah, that's useful. So probably like more evidence is required to kind of come up with that. I mean, whether pivoting on a CAT score, that segmentation, how it figures out, like probably in a long-term cohort, whether it's breaking down or not. So yes, I understand that. So Martina, just moving on to you, also worked with, you're an advisor to MSF, and also MSF work in conflict settings where in pediatric child is a focus. So how often you see, and also that's a resource limited setting, and most of the places like health workers have to kind of manage decision making. How often you kind of encountered with pediatric TB being diagnosed in sort of maybe internally displaced population or even a war or conflict driven situations? And again, is there a scope for CAD, and CAD can come in and support it? And then if are there any experience from your side to share?
Yes, I think to be honest with you, MSF is really getting into the pediatric TB world in the last few years. So after I left, but of course I'm still in close contact with my colleagues, and I think they're really trying. There are a few pilot projects that they have implemented to really try to improve pediatric TB diagnosis in difficult settings, as you say, the conflict, and they are looking at. There is certainly a scope. They are really looking at AI as one of the tools that can help in these circumstances to accelerate, let's say, the pathway to TB diagnosis for children. So there is certainly a space there. And I know they are investing quite a lot. So more evidence and more lessons learned will come as they implement and roll out this new project that they launched at the end, before the summer, that is called Tactic. It's of course then it's going to be interesting to see how you replicate this more under the national program reality that is usually less well resourced compared to an MSF project, but I think this is going to be nevertheless invaluable evidence that is going to be generated. If I may, Shibu, I just wanted to have also a comment on what Devan just said, which and what you raised in terms of the stratified medicine, which I think is really important that we are moving into this direction, that patients who can benefit of shorter regimen will be considered for them. I think in parallel we really need to think, at least based on my experience, I would love to hear what Steve and Devan think. We need to think in parallel how we keep this simple, because especially if we want to really continue on the decentralization and integration, we need to keep this simple so that frontline healthcare workers can easily implement it. And this is maybe where the AI and clinical decision support systems can play a role. I don't know, we need to think, because the more we complicate, the more decision points we make into the algorithm, the more we will make it challenging for the healthcare workers to adhere with fidelity to what it should be done. So I think we should really start now to think, okay, how do we then simplify this and give practical, pragmatic, and simple, how we translate this in pragmatic and simple guidance that healthcare workers can go and implement without getting lost in complicated diagnostic algorithm. So this is maybe where those clinical decision support systems can come and have a role. Although I must say I'm maybe old-fashioned, I think, again, one reflection that I would put on the table is that we need to keep a right balance between deploying those tools, but keep training people. I'm maybe too old-fashioned, but I'm a bit afraid of those clinical decision support systems to completely replace the human thinking or the clinical thinking process. So one thing that we should think ahead is about how do we keep a right balance. Over.
Yeah, so that's a wonderful thought, actually. So, Dr. CB, you mentioned about decentralization, and so now that being echoed by Dr. Martina, also like saying, how can we demystify and actually democratize the TB with pediatric TB diagnosis and management? That's the key question here. Any thoughts on that? It's a critical need.
I'm sorry. How can we? What? Sorry.
How can we demystify and democratize?
Yeah. Yeah, look, I actually agree very much with what Martina said. It is very wise, and that's from my experience as well. The sort of messages where we all understand where we can do a hell of a lot by keeping it simple and doing the basics well. Before we overcomplicate things, that would get us to a point where we're doing a lot better than perhaps we are already doing. But I think where do we? One of the challenges in child TB, for example, is you're not going to get to diagnosis or chest X-ray if you don't think about TB as a possibility in this sick child. At the more peripheral levels, is there sort of some way of having an app or something? I know these things are already being developed, I know, but one is in the context of TB, just to get the healthcare worker to think of TB and ask the questions that are relevant to TB would be a big step forward. While I also sort of think in the, the primary healthcare setting, with all the sick children that tumble through the door, only a few of them need referral. And the other useful tool, of course, is some sort of triage tool that alerts you to the danger signs, that gets the sickest kids to care as quickly as possible. They're the two things that I sort of often think about. I know that sounds pretty obvious, but these are the sort of things I think about.
Thank you. Devan, any reflection on that?
Yeah, no, I agree. I think maybe to make it from a research perspective, I think it's important to evaluate things in in making sure that's actually helpful. I don't know how to simplify that as much as possible. I think I get a bit wary when we talk about AI in kind of general terms and that it can solve all our problems. What if I had to encourage both the developers and the providers is to really define what we need and what we want and how the gaps can be supported through AI and through, for example, CAD. And so I think I think bringing people to care, especially from a decentralization standpoint, I think is an important thing. I also want to maybe broaden our perspective beyond the provider level to think about how AI can actually empower caregivers and providers to, I'm sorry, and patients and adolescents, to really kind of help make that decision, as myself a parent and also sometimes a patient, I think, how do I make that decision point to come in to go get a chest x-ray or to get any of those things? And how can we utilize AI to help support those decisions?
Yeah, so very interesting. So I think TB is one part of when we take X-ray, TB is one part of the problem. There will be a number of others which probably we are not discussing in this scope of this webinar. But again, there are questions coming in. Suridi, can you please come in and then help in kind of trafficking the
Yes.
questions?
Yes, sure. We have two questions so far. The first one is for Dr. Graham. The question is when it comes to encouraging families to have their children take TPT, could you please elaborate on your comments about the necessity for community engagement? In your experience, what has been the most successful strategies for driving forward community engagement or education about latent TB or TPT?
Yeah, thank you. I think from my own experience, it's developing education tools that the healthcare worker can use with the families for them to understand the potential benefits, the risks of TPT, what you're trying to treat, all of this in a local language, and with the opportunity for the families to come back a second time and follow it through. It may seem old-fashioned, but that's what we do. We in community-based treatment sites, not in facilities. The health workers are there with their flip charts, with diagrams, text in the local language, handing something to the family for them to take home, etc., etc. These are the things that we use. But beyond that is a community advisory board in the same community. A number of the people on that board are TB survivors, those sorts of things. So there's a lot of lay people, if you like, involved in the community engagement as well, so that the community becomes well educated about what's treatment for disease, what's prevention of it, or treatment of infection and prevention of disease. It takes time, but these things, there's quite a lot of this type of work going on now, I think.
Thank you, Dr. Graham. And the second question is actually open to anyone who'd like to take it up. It's asking, what is the difference in the yield of cases between handheld X-ray deployment versus conventional methods in real-world settings?
I don't know the
Any
answer to that,
question,
but
Martin?
yeah, I think you're when you say handheld, you're referring to maybe ultra portable X-ray devices, and I think in general, I don't know how much evidence there is to compare them, but yeah, I would say there's even less for children. I know, there are studies that have been completed or ongoing, and maybe Shibu, you maybe know more than I do in terms of what studies, you've been engaged with. But I think it's an open question about kind of whether they perform similarly, and then I think going back to kind of the rest of the panel's points is there's a yield of cases, maybe that speaks to the accuracy of utilizing it. But I think the real benefit of ultra portable is just being able to bring it to the places where people actually are, and thinking about some of the implementation outcomes and benefits of having that, and do it, but at the same time, how do you do that in a safe and appropriate way?
Yeah, if I
And
could
Shibu,
just.
sorry, go ahead, Stephen.
No, Martina, you go.
Very quickly, I think just to share that MSF has been looking, as part of this project that I was telling you about. MSF is looking a little bit into that, specifically for pediatric TB, how the ultra portable device perform when you need to take a chest X-ray for children, and if you get sufficient quality. So they are still working on it, but that is probably it's going to be useful and interesting to see. Over.
Thank you.
Yes, I just wanted to mention from our field level experience of partners they have used in pediatric population. Also, we have seen, AI assistance plus expert reader had helped in diagnosing more number of clinically diagnosed cases, but especially in the younger age group. But again, retrieval of sample remains a challenge, especially in the field level setting. So we have had experience from Nigeria in a nomadic population. They also extended the screening to the families and children. And now that they are doing exclusively mostly focusing on children, that evidence is coming. Yes, there is an increase in diagnosis coming in, mostly clinical diagnosis assisted by AI, but still the decision-making loop is with the doctors and the pediatricians, not with exclusively with AI. So just want to mention that.
Thank you, Dr. Shibu. We have two more questions. The first one is, how has the experience been treating children for TB for those who have HIV co-infection? Any key intervention best practices for this vulnerable group?
Yeah, I think if I may, Shibu, try and start on that one.
Yeah.
Yeah. Okay. Look, I mean, I think we've already just said that we need to develop tools that are suitable for making a diagnosis in children with TB, irrespective of HIV status, and they're informed by X-rays from children with TB, and this is starting to happen because the current systems are built for adults, and they don't perform nearly as well in children, which is what we expect. So first, I guess we need to get to the issue of improving this technology for child TB diagnosis. But the HIV issue is really going to add another level of complexity. We know that children living with and adolescents living with HIV who've usually been infected perinatally have long histories of chronic lung disease, and often have abnormal chest X-rays even when they're asymptomatic, and often end up on TB treatment, endless repeated courses of TB treatment without actually really knowing whether they have TB. So I think it's an area that requires a lot of thought and research. I don't think we're anywhere near there yet. Thank you.
Thank you for that.
Maybe one thing I would just add is the importance of including that population and, in training, and also recognizing that, specifically to CAD, that what we've seen even in adults is that you often need different thresholds to predict TB in that population, just given that they have potentially different presentations. And so just the importance of ensuring that any kind of AI algorithm is being, trained, including that population, and, is sensitive to the differences that they have.
We have one more question, which is a bit more India focused here. It asks, in terms of integration with national level TB data solutions such as Nikshay, what are some of the key considerations that surround use of AI for TB, pediatric TB, for example?
I can take it because that's more of a software integration, which most of the software companies, when they make products, they are actually interoperable and integratable with the country data systems. That's a bidirectional conversation between the country data system, and if they require, companies are open to kind of integrate that with the system. So there is a level of effort from both the sides is required for that. But we are on time, and I don't want to actually keep the experts waiting. They're all been early morning, late night, and probably very odd timing for them. So what we heard is that the evidence for computer-aided diagnosis and AI in pediatric population is a need, but it's not going to solve everything in pediatric population diagnosis, and which requires a little more clinical decision support system, indicators and other biomarkers to aid that thing completely. And also that also not solved. There is a lot of infrastructure gaps and access issues still remain as a reality, and countries and need to adopt and kind of understand the need for pediatric TB diagnosis. I think as a community, partnership is the key thing which will take us forward. And I see value in having continuing such conversations and follow-up conversations also with academic partners, implementation partners, technology partners, and also policy shaping partners. So thank you so much for all the insights you shared. This is a food for thought for manufacturers like us, and also the larger pediatric community and caregivers over there. But it's overall what I'm seeing is encouraging. Any last reflections, 30 seconds before we close? Appreciate that.
No final reflections. Thank you.
Thank you. Thank you so much. We'll meet again sometime in the union.
Thanks so much, everyone. Appreciate it.
Thank you very much, everyone.
Thanks, everyone. Take care.
Bye.
Thank you.